Does the excitement ever end? Welcome to the Puscast podcast, a review of the infectious disease literature with commentary for December 15th through 30th, 2006, the last podcast of this year. For those of you who are sick of this intro, skip ahead to the next chapter. Brought to you by Puscast LLC, publisher of the Puscast Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion. Your Uber hyperlinked electronic guide to infectious diseases at puscast.com. All the opinions are those of Mark Crislip, MD, and Puscast LLC, and not those of Legacy Health Systems, its employees, the IDSA, the IDSO, or the AMA. Now CME accredited. Listen, take the online quiz, and get a half an hour of CME free. Thanks to Legacy Health System. Also, to mention any potential conflicts of interest, I have not talked to a drug rep nor accepted anything from a drug company in over 18 years, so all the biases are my own. See nofreelunch.org for details. My honor and integrity are for sale. However, please feel to inquire within. The purpose of this podcast is to review the literature of the last several weeks and, with commentary, declaim and pontificate on those articles that are of interest to me and hopefully to you. It is not a comprehensive review. I want to get to the point, so I favor breadth over depth and cheap shots over seriousness. Keeping up in medicine is like drinking from a fire hydrant, to quote Dr. Richard Bryant, and this is my sip aimed at the practicing physician and resident. I am, if you are interested, a practicing infectious disease doc in Portland, Oregon. I do this to help teach the residents in our medicine programs. Are any of you listening? And to help me learn, but most importantly, to advertise the aforementioned compendium. But as Gag Hellfront said of another, I'm just this guy, you know? As a warning, it is not called Persiflagers for nothing. This podcast will probably contain snide comments, sarcastic asides, and short rants on political and other contemporary issues. Don't complain that I didn't warn you in advance. I am also an arrogant subspecialist who does not appreciate the limitations of primary care. There, you are warned. If you like this sort of nonsense, I also suggest you check out the Quackcast, available on iTunes, where I do a skeptical look at alternative and complementary medicine. And now, on to the literature. All the references are online, including some not mentioned in the podcast. A couple of podcasts ago, I mentioned a longitudinal Australian study that showed that circumcised males had decreased STDs over a period of time. Now there's a study that's mentioned in Medscape this month that looked at circumcision and the rates of acquiring HIV from heterosexual sexual contact, and patients were randomized to either get circumcised or not, and the use of circumcision decreased the risk of acquiring HIV from heterosexual intercourse by over 50%, 53% to be exact. This confirmed at least 40 other observational epidemiologic studies that showed an association between male circumcision and the risk of HIV. Well, it's no small thing to do circumcisions on adults in Africa, and it certainly is not a magic bullet for preventing HIV, but it's nice to know there's another tool in our armamentarium that we can use for preventing the spread of this disease. Non-Hodgkin's lymphoma has long been a known complication of HIV disease, but most people do not know that Hodgkin's is also increased risk in patients with HIV. And paradoxically, as noted in Blood this month, an increase in the CD4 cells is associated with an increased risk of Hodgkin's lymphoma in AIDS patients. It turns out that the Reed-Sternberg cells of Hodgkin's lymphoma are basically fed by CD4 cells. The CD4 cells provide the cytokines that are required by the Reed-Sternberg cells to grow and prosper. So since no good deed ever goes unpunished, as I've said many times in these conferences, by giving patients more CD4 cells and a better immune system, you are to some small extent increasing their likelihood of developing a Hodgkin's lymphoma. This, however, is not a case in Tony Bennett because, as we all know, he left his heart in San Francisco. There's my chicken imitation. Occasionally I find surgeons who won't want to operate on HIV patients. I personally wonder if it's because they're afraid of acquiring HIV disease, not an unwarranted worry given the spread of this disease by blood products. However, they usually use not fear of contagion, but the patient's HIV status is they're, quote, too sick to have surgery. They can no longer use this particular reason not to take the patient to the OR, thanks to an article in the Archives of Surgery this month. In this study, they compared a series of HIV-negative surgery patients to HIV-positive surgery patients, and guess what? They found no difference in surgical complications, wound infections, repeat surgery, need for postoperative infection, or wound dehiscence. And curiously, they found perhaps a better outcome in those who had open heart surgery than those who did not have HIV disease. Being uninflammatory is probably a good thing after you've had vein grafts. But at least based on this study out of California, you can't use the HIV status and AIDS status per se as a reason not to take the patient to the OR. Let's move on now to human papillomavirus. There was a study published in the International Journal of Cancer that documented the increased rates of tonsillar carcinoma. The rates rose by 2.8-fold, for example, in Sweden, and this was a 3.5-fold increase in women and a 2.6 increase in men. Similar studies have been done and found to show an increased risk of tonsillar carcinoma in the United States. This has also been associated with an increase in the number of HPV-16 infections found in the oropharynx. These have gone from cancers that were 23% HPV positive in the 70s, where in 2000, 68% of tonsillar carcinomas were HPV positive. So not only does HPV cause cervical cancer, it also causes tonsillar carcinoma, and is yet another reason to push the vaccine. True and unrelated, or cause and effect? Always the question when you have a case report. But there was an interesting case report in CID in an AIDS patient who had recurrent zoster with severe postherpetic neuralgia. He received a cycle of interleukin-2 as part of an HIV study to see if it affected his HIV disease. He received 7.5 million international units of IL-2 twice a day for 5 days, and at the end of his cycle, he had complete and total resolution of his postherpetic neuralgia. Now, I'm not advocating this for the treatment of postherpetic neuralgia, but this can be a particularly severe and debilitating disease in some patients, and it's something to keep in the distant recesses of your mind for future therapeutic interventions. So what would happen if the 1918-1919 pandemic hit again? What if the current H5N1 had the same mortality rates worldwide that hit the world shortly after the war to end all wars? There was a nice mathematical study that was done and published in The Lancet that looked at the breakdown of deaths in the world in that pandemic and concluded that if it were to occur with similar mortality rates, that worldwide it would kill between 51 million and 82 million people worldwide. In the United States, they estimate that it would kill somewhere between 114,000 and 744,000, based on a population of the United States of about 300 million and a worldwide population of about 6 billion. They say that on average it would kill about 64 million people worldwide and about 383,000 people in the United States, which is about the population of Portland, Oregon, where I live. So everybody around me would basically be dead. I looked for other countries specifically to support my fans in Australia and Ireland, but they did not do any particular estimations of those particular countries. Still, that's a significant amount of mortality in a very short period of time. And I, for one, am personally convinced that it is going to happen. So I've been training myself and my family to never inhale. I suppose I should be stocking up on oseltamivir instead, and there was a study published in Antimicrobial Agents and Chemotherapy that looked over time at the susceptibility of the current H5N1 to oseltamivir. And curiously, because people have not been using oseltamivir in the chickens, that this organism is become increasingly susceptible to oseltamivir, When compared to the strains from 1997 to the 2005 strains, it was about 10 times more susceptible to this agent. This is just natural variation, and I assume that once you put oseltamivir in the drinking water, that all of the avian influenza will become resistant. Resistance is not futile, but inevitable, to semi-quote the Borg. It turns out that about half of people who do not get the flu vaccine do so because they do not know they are at risk for acquiring influenza. This study was published in the Clinics of Infectious Diseases and looked at about 100 Americans and found that half of people who did not get the vaccine did not know they were at high risk. Their subjective assessment was that they were not at risk for influenza, and therefore they did not get influenza. They also found that patients who knew that they were at high risk were much more likely to get vaccinated than patients who did not know they were at high risk. So basically telling your patients, look, you have heart failure, kidney disease, chronic lung disease, etc., you're at high risk of getting and dying from influenza is a reason for patients to get the vaccine. Now, I personally think that anybody who refuses the vaccine because, quote, I don't get the flu, or, quote, I got the vaccine and I got the flu anyway, unquote, should be denied the influenza vaccine for H5N1 when it comes. Anyone who doesn't get the vaccine now doesn't get to have it later. Someone comes in with aseptic meningitis, you want a diagnosis, you do viral cultures, right? Well, maybe not so right. In a study that was published in Clinics of Infectious Diseases, they looked at 22,000 viral cultures from the spinal fluid and found a paltry 1,200 that were positive. Of these, the vast majority, 98%, were enterovirus, a smattering, 16 were herpes virus, with only 3 and 1 being due to cytomegalovirus and varicella zoster virus. The yield of viral cultures in this series was virtually non-existent, and they pointed out that if you want to diagnose a viral meningitis, it is better to do PCR, which is more sensitive and specific and has a higher yield than does viral culture. The downside to doing the PCR testing is increased expense, but it's probably more expensive to do 22,000 negative tests than it is to do a few positive tests. But as much as it pains an infectious disease doctor to say that cultures may not be of any benefit, it would appear from this series in CID that it is true when it comes to viral meningitis. Sigh. But I still think you should get blood cultures and sputum cultures for pneumonia, and I don't care what the damn guidelines say. And I will mention in passing here a review in Clinics of Infectious Diseases where they looked at 1,570 patients from 1998 to 2005 and evaluate them for a cause of encephalitis. This is a nice epidemiologic study, and the details are not to be reported here. It's the kind of article that needs to be read at length rather than hear my Reader's Digest version. Act locally, think globally. I know that's a popular catchphrase, but it's certainly true with the use of antibiotics. And when one uses antibiotics for one reason or another, you put the overall pressure on the community for more resistance to that antibiotic. This has been shown with macrolides in a wide variety of cases, that the use of macrolides, say for pneumonia, leads to resistance in, say, Helicobacter infections. This now turns out to be true due to syphilis as well, and that in a study that was published in CID showed that patients who had been recently on a macrolide were more likely to have a strain of syphilis that was resistant to the macrolide. They found that in patients who had received macrolides in the previous year, their relative risk of harboring a resistant strain of syphilis was 2.2. And they looked to see if these strains of syphilis were identical, and they were not. It's always important to take into consideration the prior antibiotic use of patients before prescribing future antibiotics for diseases, and that it does not take much for organisms to become resistant. Sometimes you just like to say the name of an organism because it strikes you as funny. At least I do. There was a case out of Taiwan of a severe watery diarrhea with bacteremia, and it was due to Vibrio fluvialis. I like that, fluvialis. There evidently have been other cases of this Vibrio causing gastroenteritis, And this was the first reported case of diarrhea with bacteremia, but I just love that word, fluvialis. What to do with some forms of endocarditis can be problematic, especially if you can't use the standard therapies. This was a review of the treatment of endocarditis that had been published, and patients received linezolid for their therapy. This was published in the Journal of Antimicrobial Therapy, and they looked retrospectively at the published cases of endocarditis treated with linezolid. They found a whopping 23 cases in 3 case series for a total of 56 patients who had endocarditis. They found that the cure rates of using linezolid for endocarditis were 63%. Evidently, 21 of 33 patients who were treated were cured with linezolid, some of whom received combination therapy with drugs such as aminoglycosides or rifampin. The mortality rate in these studies were about 33% all told. Given that linezolid is a bacteriostatic, not a bactericidal agent, I think this is a pretty respectable outcome for a drug which you only use in last resort anyway. My N of 1, which I of course haven't published, was a enterococcal endocarditis that I cured with linezolid. So for whatever that's worth, in my experience, it works. So one of the putative virulence factors of MRSA has been the Panton-Valentine leukocidin. This particular protein is found in staph and, as the name suggests, is a leukocidin. It is a protein that punches the hole in a cell wall and causes lysis of cells, and there have been epidemiologic reports to suggest that this was the major virulence factor in MRSA. This, however, may not be the case, in that they tested in mice the PVL positive and PVL knockout Staph aureus and found no difference in a sepsis model, nor did they find difference in skin disease. And they found that lysis of human neutrophils was similar in both wild type and knockout strains. So although the PVL would appear to be an epidemiologic link, in these strains in this model it did not appear to be the virulence factor that we thought it was in MRSA. Now, animal models don't always mimic what happens in humans, but there's certainly more than enough virulence factors in Staph aureus to go around. I once found a website, I've unfortunately not been able to find it since, where they listed 80 different virulence factors in Staph aureus. So this organism has no issues when it comes to trying to kill us. It knows how to do it in any number of ways. There have been epidemiologic studies to suggest that women are more likely to get infection and die after coronary artery bypass grafting. Why might that be? Well, it actually may be due to transfusions, and there was a published journal article in the American Heart Journal that looked at the rates of infection and death and found that if you had a transfusion, you were more likely to get both an infection or die after having coronary artery bypass grafting. They found, however, that this was comparing the difference in sexes, that this was accounted for by the fact that women, because they were more likely to be anemic, were to get more transfusions. And as a result, they think that the reason women were more likely to have this morbidity from open heart surgery is that they were 3.4 times more likely to receive blood transfusions than men, and those who had a transfusion were 2.8 times more likely to have an infection. Blood transfusions are not a good thing. They suppress the immune system. Oh, I hate that phrase so much, suppress the immune system, especially when it comes to alternative therapies that want to boost your immune system. But there is a detrimental effect of transfusions on the ability of the host to fight infections, and unfortunately transfusions do suppress that effect. Does this mean Jehovah's Witnesses have it right? No. Please, get real. Pneumonia. We treat it IV too long, we treat it orally too long, we do everything too long. In a study that was published in the British Medical Journal, they looked at the results of early switch of patients who had severe pneumonia from intravenous to oral antibiotics. In this study, they had patients with a mean pneumonia score of 112, which is a pretty severe pneumonia. Patients either received 3 days of IV therapy and then switched to oral if clinically stable, or they were given 7 days of intravenous therapy before being switched to oral therapy. There was no difference in outcomes in either group. If patients are doing well clinically at 3 days, even with severe pneumonia, if they are able to take oral and tolerate it, it is safe to switch them early rather than late. That it's going to take a while for them to recover from the symptoms of their pneumonia. I use a 1 to 3 rule. It's roughly every day you're sick, it takes 3 days to get better. I may be off based on a study that was published in the journal Chest in October that looked at the long-term symptom recovery and health-related quality of life in patients with community-acquired pneumonia. All these patients had a pneumonia severity index of less than or equal to 110, and they were followed long-term to see how they did. While most patients had a resolution of their respiratory symptoms within 14 days, their overall sense of well-being responded much more slowly, and that it took for most patients up to 6 months before they felt back to normal. Patients with more comorbid conditions took longer to reach a sense of wellness as a result of their pneumonia. But pneumonias take a lot out of you, and I think it's good to warn patients that it may be a while before they feel like they're back to their normal selves. Pneumonia remains a challenge for all clinicians, not of which is trying to know what the infecting organism is. In an article published in the New England Journal of Medicine, they compared the outcomes of ventilator-associated pneumonias comparing 2 different diagnostic techniques. One was a BAL with quantitative culture, and one was a simple ET aspiration. They found no difference in outcome depending on how the sputum cultures were obtained. They looked at number of days on antibiotics, number of days alive without antibiotics, i.e. how often were patients simplified with their antibiotics based on culture results, and found that basically there was no difference in outcomes either by morbidity or mortality in these populations based upon whether or not their sputum was a BAL with quantitative cultures or if they had an ET aspirate. It is interesting, and I recommend you do it, to look at the microbiology of their study. The predominant organism that they had in both specimens was Staph aureus, which occurred in about 16% of both groups. Curiously, Candida species was number 2, and normal flora was number 3. Serious gram-negative rods only accounted for about 8% and started with Klebsiella species and Enterobacter species, both of which accounted for 8%. The lack of Pseudomonas aeruginosa was quite impressive in this study. They had a mere 5% of patients who had Pseudomonas. Local rates will vary, and it's important to know your local microbiology to help determine your best empiric therapy for patients who have a ventilator-associated pneumonia, because certainly depending on your initial antibiotics, you can markedly alter the outcomes in your patients. Pick wrong, and they're more likely to die. Infection control is like the weather. Everybody complains about it, but nobody tries to change it. Now, catheter infections have high morbidity and mortality. It's estimated that bloodstream infections cost up to $54,000 per infection, 1,000 people every year. Wow, wouldn't it be nice to decrease your catheter infections? Where there was a study that was done at multiple ICUs that was published in the New England Journal, where they did a sustained improvement process that resulted in a 66% decrease in their catheter-related infections. Before the study, they were having 695 catheter-related bloodstream infections a year. After the study, this was decreased by 66%. Was it complicated? Was it hard? Was it requiring immense amounts of man hours or woman hours and difficult interventions? No. Basically, it was pretty simple, and they basically followed, get this, you ready for this? They followed evidence-based practice. Oh, give me a heart attack. Somebody actually read the literature and applied it, and they got, I don't believe it, good results. What did they do to decrease infection rates? Well, it's very simple. And physicians about bloodstream infections. They had a central line cart that had all the necessary supplies. Standard techniques. for inserting the catheters. They used hand washing. I don't believe it. Full barrier precautions during the insertion of the central catheters. They cleaned the skin with chlorhexidine. They did not use femoral sites if at all possible. And get this. This is amazing. They removed unnecessary catheters. Who can believe it? And as a result of doing these simple things, they decreased their infection rates by 66%. This is simple. Any moron can do it. It always boggles my mind is trying to get people to follow simple decrease your infection rates, especially doing full barriers in chlorhexidine. You think you are asking people to slice off their fingers. It's amazing the number of physicians who do not think that these simple requirements apply to them. Don't get me started. No, wait, you already have. But you can decrease your infection rates simply by following the standard procedures for the insertion of central venous catheters. To tuberculosis, it would appear that adipose may be a place that serves as a safe haven for Mycobacterium tuberculosis. This study was published online in PLOS One, where they found that MTB could live in fat for prolonged periods of time, and that while in fat, it did not get any exposure to INH. They found that in testing adipose patients from patients who died of non-TB causes, found that TB was frequently found in adipose tissues, but they were not aware of it. This may be a safe reservoir for TB and be one of the places that serves for relapse in the treatment of tuberculosis. I suppose that if I ever get tuberculous meningitis, I will have a permanent infection. Tuberculosis still remains a pain, and the tuberculin skin test is still not an optimal test. They reevaluated the quantiferon and compared it to the PPD in a study in this month's Clinics of Infectious Diseases. They compared 50 normal people, 50 people with active TB, and 100 people with non-tuberculous mycobacterial infections. I think what they found was interesting in that patients who had active TB, 64%, okay, 2/3 had a positive skin test. We already knew it stunk. I think it's interesting, though, that 4% had a negative quantiferon test. So this is still not a great test, i.e. 100% in patients who have active tuberculosis. In patients who had non-tuberculous mycobacterial disease, a whopping 7% had a positive quantiferon test. So 4% of patients who had TB had a negative quantiferon test, and 7% of those who had an atypical mycobacterium had a positive quantiferon test. Now, they may have been exposed to tuberculosis in the past, which accounts for their positive quantiferon test. And the other thing they point out on this test is that the quantiferon tests stay positive for a long period of time. And up to a third of them were positive 12 months after they had their tuberculosis treated. So this would not appear to be a test that's helpful for test of cure either. It's still better than a skin test. Anything's better than a skin test. But the quantiferon is still not the hog heaven we need for the diagnosis of Mycobacterium tuberculosis. And for that, I'm afraid you're still going to need an infectious disease consultant. Ertapenem rep is having a seizure of delight to have seen the study in the New England Journal of Medicine that compared ertapenem to cefotetan for surgical prophylaxis and found the superiority of ertapenem in this study. There's a lot of issues with this particular study, but I think the most important one when you're taken to your local steak dinner place by the rep to hear about this study was the number of infection rates in each group. The ertapenem study group had an 18% surgical site infection. 18%. The cefotetan group had a 31%. Almost a third of patients in the cefotetan group had an infection as a complication of their surgery. It makes one wonder if they were washing their hands, wearing gloves, etc. Now, there are a lot of things you can do to help prevent surgical infections. Your institution should be involved with a SCIP initiative, wherein you keep the blood sugars low, you don't allow shaving of the surgical site, you make sure the patient gets the correct prophylactic antibiotics. You make sure the patient is kept warm in the postoperative period. You make sure that the patient's kept oxygenated in the postoperative period. By doing these simple things, your infection rate should be under 10% for bowel surgery. Certainly having a whopping 31% infection rate in the cefotetan group makes the whole study somewhat suspect. The other issue is, do you want to be using ertapenem in your hospital? Breeding resistance is inevitable, as we talked about with the macrolides earlier in this podcast. Using a little bit of macrolide here and there rapidly led to the resistance of syphilitic organisms to macrolides, and one would expect that the use of an ertapenem in your hospital would quickly lead to resistance to meropenem and imipenem, drugs that are of great importance in sick patients. The problem is that now this is in the New England Journal of Medicine, and it sort of sets the standard. And I think before you approve of this in your surgical committee, you should at least read the editorial about the wisdom of making the switch from ertapenem from the cefotetan. The problem, of course, is that currently cefotetan is not available, and finding the correct antibiotic to give under these circumstances conveniently is problematic. Now, when a drug comes out, I try to avoid using them initially unless I have no other option. Over the years, I've seen many patients die and drugs being taken off the market because of toxicities. The latest one that's heading down that pathway appears to be Ketec. Ketec, telithromycin, has been voted by the FDA now to only be used for pneumonia and marketed that way only. Although it has shown efficacy for bronchitis and sinusitis, the liver toxicities with death due to liver failure make the risk-benefit of Ketec not worth it in the estimation of the FDA. Ketec has been used heavily in the United States, evidently, and evidently they sell at least $71 million a year of this product. I have yet to give a prescription for Ketec, following my rule of letting other people kill patients in the first year after a drug is released. This conservatism, which is otherwise unusual for me, has consistently been proven a wise course. The other drug toxicity thing to mention this month is a nice review in Clinics of Infectious Diseases on the drugs that cause torsades de pointe. There, how's that for a French accent? Jeux d'enfants, you know? So if you are interested in the effects of macrolides and quinolones on your QT interval, there's a nice review of this in the Clinics of Infectious Diseases this month. The last podcast, or at least in the last references, I mentioned a Japanese study that showed seasonal variations in tuberculosis disease. Now there's a study that's published in the journal Critical Care Medicine where they looked back on ICD-9 codes in patients with sepsis and found that the rates were much higher in the wintertime when the rates of sepsis were about 48 per 100,000, and that the rates were lowest in the fall when the rates were down to about 16 per 100,000. Sepsis they thought was highest in the winter because the source was usually respiratory, and not unsurprisingly, respiratory infections are higher when people are crowded together in small rooms. So don't get your flu vaccine. I think we need to keep our ICU nurses busy, and we can do that by letting you get a severe respiratory illness and subsequent sepsis. I'll finish this month just to point out that the CDC site has 2 articles on waterborne disease and outbreaks, one associated with drinking water that's not intended for drinking, which surprisingly is not a good idea, and the other is waterborne disease and outbreaks associated with recreational water use. These are good epidemiologic studies that help any physician better understand the epidemiology of infections associated with water sources. Well, as they say on Car Talk, you've just wasted another 30 minutes of your life. This is the end of this Persiflager's podcast for the last 2 months of December 2006. A review of the infectious disease literature with commentary. References, including some not mentioned in the podcast, are available on the website, which is now searchable through Google. Now CME accredited. Now that you're done listening to my inane babbling, take the online quiz and apply for a half an hour of free CME. Thanks, as always, to Legacy Health System. This is brought to you by Pusware, LLC, publisher of the Persiflager's Annotated Compendium of Infectious Disease, Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases, available at pusware.com. If you like this, try out the Quackcast, where I review aspects of complementary and alternative medicine with a skeptical and sarcastic viewpoint. I recently got as high as 21 on iTunes, so I'm very psyched about this. Bandwidth ain't free, so feel free to purchase the compendium and support this podcast. It's copyright with the Creative Commons license, creativecommons.org. The music is by my son when he was 12 years old, improvising on the guitar. For comments, complaints, and general kvetching, email me at mcrislip@pusware.com. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.